chairpersons, and good evening. We are running late, so I try to catch up with it. So after a very, very interesting talk, both on ED and TCC insertion, and I'm very happy that my student has grown to a very big level. We will now deal with something more advanced in interventional nephrology, and that is the AV fistula repairs. So I have nothing to disclose, and over the talk we will cover from no flow in the AV fistula situations to high flow AV fistula situations. So one thing that was just mentioned about the catheters. So we must understand that AV fistula is not benign, it is toxic, it is a non-physiologic anomaly, and most of the time fistula toxic effects are under-recognized. As we said, they fly below the radar, so don't get detected. The fact is that better vascular access leads to better patient survival. Ideal dialysis conduit is elusive, and there is scarcity of vascular access estate. So gone are the days 20 years ago when we used to say, oh, fistula has failed, let's make a new one. Nowadays we have patients who have only one fistula which is working, all other sites are exhausted, and we have to somehow salvage that fistula. So in the situation where that we don't have much vascular access estate, we have to see what best can be done. Also not to forget that fistulas can fail early and late. The causes are juxta-anastomotic stenosis and presence of accessory veins. Both these can be diagnosed by physical examination. You don't need any fancy gadgets for it. Late fistula failure is the one which occurs after 3 months, and it is usually due to outflow stenosis, and venous stenosis is again clinically detected by symptoms, which I'm sure you all know. So we need to improve the vascular access outcomes, and the best thing to do is to have a right access in the right patient for at the right time for the right reason. This is what is mentioned in the latest state of the guidelines, and we of course know what is the nature of fistula. All this rule of 6 is known, but also not to forget that good fistula function depends on cardiac output, blood pressure, artery size, and quality of artery. Never forget that. The fistula is a circuit. It starts from the heart, ends in the heart. It has an inflow, it has a body or conduit of the fistula, and it has an outflow. And all 4 components of this circuit, heart, inflow, body, and outflow, are important. So we have to look at all those in totality rather than looking at one particular. Now, why do fistulas not mature? Let's start from here. So you have a fistula, and after the creation of fistula, you have one of the two things. Either there is inward remodeling, as we call it, or there is an outward remodeling. So this is correlated here, and these are from the right. These are the pictures from a brachiobasilic fistula, which was made second stage. At that time, these biopsies were done. So we know that these are all real situations. So if you have inward remodeling, and which is hypertrophic, then you are going to get narrow. This fistula is not going to match. You will find that vein is very good, but this fistula will not match. But if there is outward remodeling, let it grow as much as it wants. It's like enlarged prostate. Lateral lobe enlarged, no problem, so long as medial lobe are flattened. Patient has no urine. Exactly same thing happens here. Let it grow outward as much as it wants. Whether it is hypertrophic, eutrophic, or hypertrophic, these fistulas are going to work. Also, as you make a fistula, there are some upstream events which occur, which is surgical injury, which has been described in the earlier lectures. There is a hemodynamic shear stress, which is shown here. Trauma, which could be due to needle. If it's a graft, then PTFE. We have done an angioplasty where we have actually damaged the intima of the vein. Leads to downstream events which are oxidative stress, inflammation, proliferation, migration, and things like that. So once you have created a fistula, it is possible that you will have some upstream events and led by downstream events, and that's ultimately what is going to lead to malfunction of that fistula. If we are going to have malfunction of that fistula, we need to do something. So the earlier work on this was done by the radiology colleagues, and this was the paper published where they did treatment of stenotic lesions in the dialysis access fistula and shunts by transluminal angioplasty. So this was the early days, and radiologists had it. It took this particular man who I am standing next to him. He is the doyen of interventional nephrology in the USA, Dr. Gerald Bethard, and he, way back in 1984, after being a nephrologist, went to his cardiology colleagues and told them, look, teach me, this is my problem, these are my patients. He learned from there, and he pioneered this American Society of Diagnostic and Interventional Nephrology. This is the picture of 2020 at last ASDIN in person at Las Vegas. So he taught the whole world what should be done. Now, when we have AV fistula lesions, they are classified as type 1, type 2 and type 3 lesion. Depending upon where they are located, in the juxtaanostomatic vein, away from vein, or in the inflow of the artery. So depending upon that, I mean, this is just theoretical. So when I tell you that, look, I'm dealing with grade 2 lesion, you know what I'm talking about. Otherwise, it does not much mean. And again, this is the correlation between what is there on H stain and on Mason's trichrome stain. You will realize that as there is a narrowing, there is the intimal medial hyperplasia, and this is what we call as inward remodeling of the vein. Now, one more thing we must not forget is how we puncture veins. Okay, so if you are going to use a cutting needle, which most of us use, we don't have blunt needle anyways, and if you are going to puncture it against the direction of the blood flow, and if you go straight like this, it will raise a skin flap, and this skin flap will then leave a place where it will bleed, form a hematoma, and repeated puncture through that will then ultimately lead to narrowing. Thrombosis always leads to narrowing of the vein. So it is always a good idea, if you are using this kind of needle, to rotate it to point the sharp end upwards, away from the lower vein. So, okay, we make fistula, we have success, we have failure, it just dies, okay? And then we have a big chunk of patients who have FTM, so failure to mature, okay? FTM was a paper published by Charmin Locke, who came here way back, and they have a scoring system. If you are interested, I can share that paper with you. One of the authors is Dr. Hemant Mehta, when he was in, he's practicing nephrologist in Mumbai, and he's one of the paper of author of this, co-author. So you have either successful assisted maturation or you have a disaster. So we have to try something. So let's see now some cases. So what do you do for this fistula? So this fistula was made well in advance, 8 months ago. Patient now comes up, he needs dialysis. We thought of fistula is in place. We try to look at it and we can use it for dialysis. It's taken up for angiography with juxtaanostomatic stenosis. So there are two options. One, do intervention. The second one is make a fistula, which is proximal. Third, make a jump graft. That's also a possibility. But for all those who would try to say that, look, easy to make a new fistula, is there any guarantee that that new fistula also will not have a juxtaanostomatic stenosis? Unlikely to predict such thing. So better is to try and repair this endovascularly. But if you have this situation, so another fistula made well in advance. Look at the draining vein, it has just not matured. This is gone, a dead fistula. So now what about this? This is also looks like a dead fistula, no vein seen. But somehow this was acute thrombus, we could pass the wire and see the end result. Patent fistula. Okay, so it depends. We have opened up fistulas up to 1 week old, 1 week of thrombosis. One patient I opened up for 1 month old. It worked for 1 month, but it failed. So I decided no. 1 month is too much of a period, we should never attempt it. Now, how do we approach this fistula? So we have done it through venous approach, so you can use single sheath, vascular sheath in the vein, antegrade or sometimes antegrade, retrograde. Radial artery approach, which is like in thing, we've been using it. Sometimes it helps to, as I said, you have to go from heart to heart. So it is better to go femoral artery approach than straight. Why it helps us sometimes, I'll show you in one of the cases. I've done only one brachial artery approach and realized no, I should not do it. It's an end artery. The most important thing is there's nothing to press against. There's no bone. So you try to tie it, you will compromise the fistula. You will actually lose the fistula which you have repaired. So there are many proponents of brachial artery puncture. I personally feel no, it should, and I think it's been earlier it used to be done. In fact, one of the past president of SDIN came to Global Hospital and he did demonstrate brachial artery punctures and taught the students there. He told me that, but I would personally not do it. Okay. So this is a 49-year-old female who comes with no flow situation, diabetic, no fistula in place, pre-ESRD. Dialysis started right at ECC. Fistula is created. As standard, every patient after fistula is called for a follow-up after 15 days. Fistula is working well. 10 days later, fistula is not working. Obviously, there is a thrombus. What is to be done? So this is radial artery. No vein is seen. We go through the radial artery. We manage to cannulate the vein. Now something is seen here, but of course there is a thrombus here. So this is 1 month old fistula roughly. So angioplasty is done. You see this filling defect here, which means the thrombus is persistent. So we did it 3 times. Nothing is happening. So such a narrow vein, 1 month old, not arterialized. We can't put a venous stent, which are big ones. So we decided to put 4 by 50 millimeter coronary stent. So that was put here. We thought everything is fine. Oops, there is a problem. So when we deployed the stent here, that clot which was here got migrated onto the arterial side. Luckily, this is balloon mounted stent. So balloon was there of this stent. So we used that balloon, dilated this segment, and in the end we had this result. This fistula is working well now, several years. Another situation, poor flow, 55-year-old diabetic, left brachiocephalic fistula, reduced 3 months after creation of fistula. This is the reason. So plasty is done. Again, as I said, look at the whole circuit. Further upstream, this vein is narrowed. So another plasty is done. This is how it is, and this is the final show. So we are happy, but story doesn't end there. 4 months later, when she is being dialyzed with the fistula, again flow problem comes. So now you see the whole vein. There is a narrowing here, there is a narrowing here, and maybe there is a narrowing there. So vein is diseased. So again, angioplasty is done, and again the vein is restored. Nice cephalic arch, etc., etc. Okay, so this is what one can do. This is very interesting case which got accepted as a poster in last ASDIN. So this is a lady who was, you see this finger almost gangrenous. She would have severe pain during dialysis in this hand. And one would think that this is what we call as distal and hypoperfusion ischemia syndrome, DHHIS, this or dialysis excess related sterile phenomena syndrome. But no, that's not there. So now see, this is around elbow area. You see this puncture marks here. So this is artery, this is vein, as we will do it otherwise. And she would get severe pain here because this is the reason. So this vein in the arm, beyond this point, beyond lower arm, the whole cephalic vein is like this. Because of which this accessory vein has developed here. So when the blood is returned from here, it actually gets diverted all the way into the hand. So there is a venous congestion, venous hypertension, and that's the cause of pain. Okay. So what we had to do was to sacrifice this vein. So you see this, these are the coils. So we do coil embolization. We did coil embolization, mark the points, told her, use this for artery, but use, see, luckily the other vein, basilic vein is good. Okay. So this is to be used for the venous return. Within a week, this has healed completely. 1 week, this hand has become normal, she is paying. So again, you have to study the whole thing. So if we had done only venous puncture and things like that in such situation, it won't be helpful. And there is one condition which is known as BAM, balloon assisted maturation of AV fistula. Now that has many meanings. Okay, balloon assisted maturation in the true sense is actually very different. But then people do it in a different way and they still do. So like this. So whatever the KWK guideline says in practice, when we say after 3 months we should assess the fistula by angiography if it is not matured, it's easily said than done, nobody. So like when you start telling the patient by 3 months, he will agree by 6 months. So this is 6 months old fistula which has not matured. And what is the reason? These are the lesions here in the outflow. So this lesion is tackled here. This lesion is tackled here. This fistula is nicely matured, and within a month now we are able to use this fistula. So this is what we call as balloon assisted maturation of AV fistula. So if fistula is not maturing, most of the time there has to be a cause. The cause has to be in the form of venous stenosis or whatever nature. Look at it and try to rectify it. Now let's talk about late functioning. So this is a 53-year-old diabetic female on dialysis for 5 years. One night she calls in panic, my fistula is closed. I said, come down now. No, it's too late. I'll come tomorrow morning. Next day morning she says, my fistula is working. I'm not coming. No, I said, no, now you better come because I have to see what has happened to your fistula. The fact is that fistula did close down, though transiently needs evaluation. Likely there was a thrombus which got spontaneously dislodged, possible. But the question is, why did the thrombus form in the first place? The thrombus forms in a 5-year-old working fistula only and only because of underlying venous stenosis. Always remember that. Thrombus just does not form out of the way in a flowing system. Unless, of course, there are other causes like hemoglobin has gone to 15, nobody has checked the hypodose. Those are different situations. But otherwise, why should it thrombus? So, this is what there is a thrombus here. We also made sure that the palmar arch flow, ulnar and radial is good enough. So, a thrombosuction is done. There is a narrowing here, as you can see. The little thrombus is still remaining there. So that means there is an acute thrombus here, and you see the color of this consistency, you can make out this is acute thrombus, this is a chronic thrombus, this is hard. You can actually feel it, visualize it. So angioplasty is done. Okay, but not so good. So second angioplasty, still not good. So one more angioplasty, and then the final shoot. Nice fistula. Working for last 7 years now. Okay, so total 12 years. In between she had 1 cadaver transplant, which way she continues to be on dialysis. Okay. This lady was to be posted for transplant on dialysis for 3 years. This is just last month. And fistula closes. Just before the transplant. Now, what is the option? Okay, forget it. We'll put a pumpkin and take her. So no, let's try to see. We have come through radial approach here. Vein is not seen. So now when we position it properly, there is a thrombus here in the vein. There is a big thrombus load here. Okay, after thrombosuction. So the radial catheter was positioned in such a way, manipulated. Now it is going only in the vein, not in the artery. Patient is sent to the ICU, where RTPA infusion was given, altiplase 20 milligram over 10 hours. We have a protocol of how to infuse local thrombolysis, and patient was called next day for check sheet. Nicely open vein. So you can do just thrombolysis. Of course, angioplasty was also done, but this is not. Sometimes, as I said, you can come with the vein. So you can come from the radial artery. This is the arm fistula, and there is a narrowing here. There is a brachiocephalic fistula here. So you can just come from the vein. Study this. It has opened, not very nicely, but it has opened up. The fistula will work. But why we need to study the whole circuit is this. So this is a fistula. Nice. Nicely developed brachiocephalic AV fistula. Moment we puncture, the vein would collapse. And several attempts. Like this guy might not have punctured it properly, that guy may not be good. So we said, okay, let's study it. You know where is the lesion? In the subclavian artery. Subclavian artery is narrow. So obviously there is an inflow problem way there on the left side. So that's not feeding to the fistula. So moment you put the needle in and try to withdraw the blood, that subclavian artery stenosis causes a problem. So angioplasty is done, a stent is placed there, fistula works well. That fistula was working now for 5 years. So problem was somewhere else, and we will be looking only at the vein sometimes. So we have to study the circuit. Now this was a video which I have just uploaded. Those of you who are member of Indian Society of International Society of Nephrology, there is an ISN Academy. So I have put up a video saying TCC laterality and AV fistula functionality. Okay, so if you happen to have fistula and passed catheter on the same side, you are likely to be in trouble. So this one says contralateral TVC group had higher rate of AV fistula function at 6 months but not at 12 months. But we do find this problem where patients who have had fistula, TCCs or non-TCCs and then happen to have fistula are in trouble, like this patient. So he has had multiple fistulas. Now somebody makes the right brachiocephalic fistula and he comes with swollen arm. Very severely swollen tender arm. This is the reason. It's completely thrombosed here. And now we have to go through, we have come from below, but now we have come from the fistula. Now we know this much is the gap to be bridged. It's very, very difficult. See, you need that soft and see how you have to probe. We know we are going to reach there. Just see. I'm just doing it. And I know where I have to hit. One moment, it will go down. There you are. So this sort of persistence and perseverance is required while doing this procedure. You can't do it in a hurry, in 5 minutes. Okay, another patient. So he had left IJV TCC and somebody made now a fistula on the left side and he came with swollen hand. So we had two options here. Either I said, when I looked at it clinically, I said, why not make a fistula on the right hand? Keep the left sided catheter, we'll close this fistula. I said, no, don't touch my fistula. I want the fistula. You do something else. So we had to put the TCC on the right side. Right IJV was thrombosed, right EJV was patent. So first we made sure that EJV is patent so that I can put a catheter there before I could remove this. So once this is removed, after putting the catheter in, now this is CTO. Very hard. So what I am doing is I have taken the opposite end of a glide wire. One is a soft end, one is a hard end. So see, I am probing and probing and probing. See, I am literally drilling rather. See, You need to do this, but with the conviction that yes, I am going to reach. Yes, I have reached there. Okay. Now I come out, and now I go with a soft end. Now you don't put the hard end further. Now I come with a soft end. See, now I've gone in. Okay. Once I've gone in, I'm through that lesion. I can remove this catheter. I can do the plasty. So this is the plasty is done. There is an elastic recoil. Stent is put, and swelling settles in 24 hours. Fistula can be used. In the meantime, what we did was first put this catheter here. Why? Because now you see this is your right percussive lubricant, this is your left percussive lubricant. Whenever you put a stent, you should make sure that this line, this passage, the right brachiocephalic SVC junction is not jailed. If you jail that, that means your passage through this is closed forever, it's gone. So you have to make sure, and in order to be sure that we are not going to jail that passage, we had to put this first before we did this stenting on the left brachiocephalic vein. So you have to just remember that don't try to compromise any other vein when you put a stent to open up another vein. This sorry state of affairs, 27-year-old boy, tall, obese, multiple catheters. And then the catheter is not working. Oh, let us pull it, pull it, pull it. Oh, now it's working. Let's pull it now. So ultimately, you see this. This is your right brachiocephalic vein gone, and this is your SVC RA junction, SVC gone. So two stenosis in the vein, and somebody made a fistula here. He became grossly symptomatic. 10 kg weight plus, he cannot lie down, he is breathless even in sitting position. How to dialyze him, we don't know, and he comes to me. Okay, so we had to face this. So all roads blocked, including, now this is another, the patient's father said, doctor, do this, I want to go for transplant. I will go for transplant. IVC is blocked here. This is the femoral here, and this is the IVC here. So somewhere here there's a block. So where are you going to put the kidney also? So that also is gone. Everything is spoiled for this man. So we had to at least give him a working fistula. So this is the block here. These are the veins on the left side. So you can't make can you make any fistula on the left side? This is all closed. So even if you make fistula like this, that will get swollen. So we tried. This would just not go over. That wire would get curled here. SVC is blocked. You know what is this vein? This is the azygous vein. The azygous vein fills only and only when SVC is thrombosed. Okay. When Zahir was talking about, if somebody is interested, just last Monday I've done a case. The patient had a thrombus, SVC, stenosis, fibrin sheath, and filling of the azygous vein. Everything in one film. It's a classical teaching study. I can share it with you. So we were about to give up. Then we said, why not do this plastic? Once we did the plastic, this end opened up, and then we could go further. So now see this. This is plastic. This has opened up, and we have put stent. We made a mistake. First we put a stent here in our own over enthusiasm. Didn't realize when we tried to take another stent through this stent got dislodged here and got spoiled. So now now you see there is one stent and we have put another stent here, and then we have put this stent. Within 1 week, 10 kg weight loss, no breathlessness, patient is able to lie down. So, last case. So this is Miller's banding procedure. Okay. So I'll skip this video. So this lady had a fistula left brachiocephalic 6 years ago, and then we had in 2017 did angiography and angioplasty, and we had found a working fistula which worked for 5 years, and now she comes with this. This is the fistula. This is a dilated vein over her chest wall. This is a dilated vein over her neck. This is the left side of the neck. She has not even taken bath because it's painful, extremely painful, throbbing. So the procedure is this. So this is a high flow fistula. A balloon is placed endovascularly. Usually a 5 French, though there is a normogram available as to for which vein, how much flow reduction, what size of balloon. We make a dissection along the vein here, marked it here, and tie a knot over the balloon. Balloon is deflated and removed. Now this is a deflated balloon. This is narrowed. This is exactly what is described in the original paper in Interventional. You have done exactly same bending here as shown there. Or you can use this vessel dilator as a dowel and tie it over that. That's a mod. Some people use the dilators of our TCC catheters and tie it, but that requires dissection of the vein. So this is the final thing. We did this. The flow volume, the flow through the fistula volume, which was 4,000, came to 800 ml. So we tied and online checked the flow volume and make sure that yes, we have achieved this. Within 15 days, this is the hand. So flow reduction has helped her. So Miller's bending procedure is something which is usually used for Still syndrome, but can be also used for flow reduction. And this is my last slide. So I conclude that we had a beginning where we had stalwarts, Randy Scribner and all other guys who came with Semi-Mind, Brescia, etc. And the Nephrology intervention, Dr. Gerald Deckard. And today we are doing all sorts of interventional procedure to salvage AV fistula. Thank you very much.